everybody, it's Dr. Alex Earle. We're here at Pure Plastic Surgery, and it's Wednesday. It's Hump Day with Dr. Alex Earle. So I know we switched the times on you a little bit today, but I'm just glad that we're here, we're on, and we're live, and I hope you guys can join me, and of course, ask your questions, and I'll be happy to answer them. But today I wanted to get started showing some data from some recent meetings of gluteal surgeons basically that have come across the world. So as you know, I am a member of WAGS, which is the World Association of Gluteal Surgeons, okay? And WAGS recently had a meeting here in Florida just in January, I believe. And they compiled data from world-renowned experts in mainly BBL surgery, or what's otherwise known as liposuction with fat transfer to the buttock, okay? And they've compiled that data from these world-renowned experts, and they've come up here with some numbers that I wanted to share with you so that you're aware of kind of the realities of this procedure. And these are world experts mostly from Europe, the US, and Central and South America, okay? So the first thing they wanted to point out is the revision rate. So basically, across the board for world-renowned experts in BBL, the revision rate is approximately 10 to 15%. Okay, 10 to 15%. And so I think I would like to say that probably our numbers here at Pure are lower than that, but there is a revision rate associated with the surgery because there are so many factors that the surgeon cannot control that typically happen outside of the operating room, and some factors that have to do with the patient themselves, which of course the surgeon can't control as well. So what are the patient-related factors? Of course, a lot has to do with genetics. So what is the quality of the skin? What is the quality of the fat? Those things can be genetically based, although the skin can also be based on what happened prior. Did the patient have multiple pregnancies? Did the patient have massive weight loss? All these things affect the quality of the skin as well. The quality of the fat probably may have to do with diet as people grow from childhood up into adulthood, but we don't really know. There's also definitely a genetic component there. I do hundreds of liposuction and BBL cases throughout the year, and I can tell you, no patient is alike. Some patients have very yellow, thicker fat. Some patients have a kind of a more thinner, kind of pink fat, and then some patients get kind of bloody and have this kind of bloody fat there as well, very, very fibrous, okay? And you can't really tell, just by looking at someone from the outside, what kind of a quality fat they're going to have. Okay, so those are some factors there. Then of course, post-op care is extremely important. Do they go, do you use the correct compression? The therapist, the massage therapist is extremely important. So there's a lot of factors that go into the surgery as to that that kind of can change how well skin retracts, how well fat survives, and things of that nature, making it have a across the board revision rate of approximately 10 to 15%. Okay. The second thing they wanted to talk about was fat retention rates. Okay. So that again, if you put everything together across the board, all the different techniques that people do, the overall fat retention rate was quoted as being approximately 50%. Okay. As you all know, I typically quote mine at being at approximately or the average being approximately 30%. I think that's what I found kind of with my own personal data, okay, that there's about a 30% loss, okay, and a 70% retention rate. But overall, I guess across the board, they say that it's approximately 50-50, okay. And then in terms of round two, so these are round twos, these are not revisions, but people that want to go back for a second round. It looks like the round two rate is anywhere from 15 to 20% across the board. These usually fall into two categories. You have those patients that are the higher BMI patients that typically want to go back to get more lipo, because if, say, for example, in a place like Florida, we have a limit as to how much fat we can remove. 4 liters is the max. And if your BMI is 30 or higher, then you'll have more than 4 liters of fat within your body, and therefore you may want to come back a year later to do a round two. Then there's also patients that want just a larger buttock, more of a vixen look, when you're doing things safely, when you're placing the fat in that safe zone, in that subcutaneous space between the skin and the muscle, sometimes it's very, very hard to get some of these extreme vixen looks in one round, and so those patients want to come back for a second or third round. Okay, and then you have the other end of the spectrum. You have the patients that are on the lower BMI scales. Usually typically my lowest BMI is around 22. Below that, there's just not enough fat to do really much of anything. But if you're say between 22 and 25, you're definitely considered to be on the lower BMI side for BBL, what we call skinny BBL, and perhaps those patients then would want to come back for round 2, just so that we can harvest more fat and give them a bit more projection, or more volume, more shape, or whatever it is that they want. Okay.
Is there something that your patients can do post-op to increase the fat retention?
Yes, of course. So I know. So and I always say this, and then people say, well, this doctor from Colombia said this and this stuff. So every surgeon has their own protocols and their beliefs, and it's mostly based on their personal experience after doing hundreds and hundreds and hundreds of cases with their patients. So based on my personal experience with my patients that are doing hundreds and hundreds and hundreds of BBLs, is that the post-op care is important in 2 ways. One is in not putting pressure on the hips or the buttock, okay? Because we do place that fat in the subcutaneous space, okay? I think that's the main reason there's a difference between some surgeons, say in Colombia, and what used to be in the DR. The DR has the same rules now. They can't place it beneath the muscle. But I think if you place the fat beneath the muscle, then the whole thing about the pressure and everything else is not as important, because the fat is placed deep, and the muscle also has a better blood supply. But of course we don't want to do that, because that's where the dangerous vessels are, and that's where you can potentially get a fat embolism and then have an unfortunate, really, really bad outcome, or death. Okay, so we place the fat in the subcutaneous space, and because it's in the subcutaneous space, then the blood supply is not as great, and it is more susceptible to issues having to do with pressure. And so therefore, it is really extremely beneficial to try to avoid pressure to those areas in the first 6 weeks post-op. The other thing that I believe in, and I think many surgeons do, I do believe in what we call quote-unquote feeding the fat. So you definitely want to maintain a diet that is high in healthy fats. These include certain nuts, these include avocados, salmon, high omega-3 fatty fish, and also some kind of milk products, some ice cream and milkshakes, so you can enjoy your chocolate shake as well. But I think feeding the fat does definitely have something to do with it. You don't want to be in a fat burning state. You don't want to be in a weight losing state after your BBL, because I think that will lead to a lower retention rate.
One more question about retention.
Yep.
Does the surgeon's technique have any impact on the retention rate?
So I'm sure it does, but there is no one technique that has been shown to be superior to any other. So what does that mean? It means that hundreds of surgeons throughout the world, they all do it a little bit different, and some will centrifuge the fat, some will add PRP to the fat, some will only the limit as to how much fat they transfer, and things of that nature. And if you look at all the medical literature, surgical literature out there, there hasn't really been one singular method that's been shown to be better than any other, because if there was, then we would all then just employ the same method. I mean, that's the beauty about science, right? Science and medicine is that when one protocol comes out that is shown to be significantly superior to any other, then it becomes public knowledge, and then people use that protocol, right? So unfortunately, I guess fortunately or unfortunately, nothing has really been shown to be quite superior. So people try different things. Like I said, they try centrifuge, they try PRP, they try all these things, and it really always comes down to, I think, a similar fat retention rate, which is somewhere, I think, somewhere between 30 to 50%.
Do you recommend stopping keto before surgery?
Certainly, yes. You don't want to be in a fat burning state before a BBL type surgery. So we're talking about specifically about a fat transfer surgery, okay?
Yes.
It doesn't matter as much for other surgeries, but where you are transferring fat, where you want to get that fat to survive, you want your body to be in a catabolic state, not an anabolic state, not a catabolic state. So you want it to be wanting to retain fat and not burn fat, okay? All right, so I just wanted to go down to the next one here, infection rate. Infection rate across the board, world-renowned experts approximately 10 to 15%. Okay, and so that may be. Some people may say for cosmetic surgery it's a little bit on the higher side, but remember, we are working on the buttock. Okay, and I think that's the reason why it's a bit higher overall is because we're working near the anus, and the anus is a very, very dirty area that has lots of bacteria. And so for that reason, the infection rate for a BBL is going to be significantly higher than, say, an infection rate for breast augmentation. The infection rate for breast augmentation across the board is probably about 1 to 2%. Okay, much lower. Why? Because we're working in a completely clean, completely sterile area. Okay, but the BBL, by definition, the butt lift, we're working right near an area that is not completely sterile. Okay, it has lots of bacteria. So yes, of course, we direct the patients, we give them antibiotics and do everything we need to do. But by definition, we're just working in an area that is not as clean as other areas of the body. And so I think, at least that's my opinion as to why the overall infection rate is a bit higher for that procedure. Okay.
Do you know the pure plastic surgery infection rate?
It's probably actually from last year. It's probably about 5%. So I think it's significantly lower. Why is that? Of course, we take all the precautions that we're going to take, but this is a question actually that I get from a lot of patients. They ask me, Dr. Earle, did you really want me to take those 2 antibiotics that you sent me? And of course the answer is yes, I do that purposefully. So all BBLs actually get two oral antibiotics to take for the first week after surgery. And so that's just my protocol. I think it does help. I know some patients are surprised when they see that there's 2 of them there, but I think that's just something I like to do to try to be extra cautious in the perioperative period. Okay, and then here's the big. I think this is a big question mark. Okay, now because people have changed their techniques, but the mortality rate for a while was 1 in 3,000. Okay, it was 1 in 3,000 when perhaps the knowledge wasn't really out there as much that injecting into and beneath the muscle can be dangerous. Perhaps there wasn't as much knowledge about the anatomy as to where the superior and inferior gluteal vessels are exactly located. And of course, there were many BBLs being done by non-professionals, by people that are not plastic surgeons. So people that really don't have the knowledge of the anatomy and everything, and also the access to the medical literature. And so it was being done in a dangerous way. And I think that's what kind of prompted this fairly high mortality rate, which is mostly due to fat embolus, which is when fat is being injected inadvertently directly into one of the big gluteal vessels and causes a fat embolus. Okay, I think in the next year or 2, once we start to compile more data, once all the members of WAGS, or the World Association of Gluteal Surgeons, compile all their data, you're going to see that this is going to be way off, because now we do understand the importance of staying in that subcutaneous space. A lot of us, including myself, use the ultrasound when we're near that danger zone to make sure that we're in that safe space. Okay, and so when you go to a surgeon that's double board certified, that is true, in one of those board certifications is in plastic surgery, or in other words by the American Board of Plastic Surgery. Okay, and that surgeon has a lot of experience with the BBL and is even taking extra precautions such as using the ultrasound to guide them during the BBL, then the procedure becomes very safe. Okay, so I think you really want to keep all those things in mind when you're choosing a surgeon. And I know some people are like, I just want 1 round, I just want the super vixen look, I'm going to Colombia or wherever. I urge you to please, go to someone who is not routinely injecting in or under the muscle, because that can potentially put you in danger. So you don't want to do that. Okay. All right. So that's kind of the summary of some of these numbers, and I'll be happy to, of course, take multiple questions out there.
So in a case where one of your patients should get an infection, what would you recommend them to do, and how can they see that they have an infection?
Yeah, so that's a great question. So the first sign is typically either pain or redness, or both. Okay, and that the patient needs to contact us immediately. And typically the first step is to start on 2 oral antibiotics. And if we're able to get on top of it right away, sometimes that's sufficient. And 2 weeks of oral antibiotics and the patient gets better. But that's not always the case. So sometimes if you're on a few days with oral antibiotics and things are not getting better, then you do have to go to get IV antibiotics, which typically has to be done in a hospital setting. So you have to go either through the ER, but of course this is all going to be in communication with us. And if you have to do that, then you go to the ER, then start using IV antibiotics. And sometimes we do some imaging, such as an ultrasound or a CAT scan, to see if there's any fluid that's trapped inside. If there's fluid trapped inside, then there are a couple of things that can happen. One is you can get what's called a percutaneous drain. Usually an interventional radiologist can do this, and that's really the best option because it's not a big, it's a very tiny incision. They put the drain in the area, they drain the fluid, you are the antibiotics, and you tend to get better. Sometimes though it does require surgical intervention. So surgical intervention requires an incision, usually about an inch or so that fluid can get drained, the wound can get washed out, and then the wound's allowed to heal from the inside out.
Since you've been a professional, do you know how many BBLs you've performed?
Okay, I have to get an exact number on that. It's between 800 and 1,000, somewhere in there.
And how many surgeries do you do a day, and how do you determine the order of surgeries?
Yeah, so still, we're still not doing more than 5 surgeries a day here at Pure Plastic Surgery. I've always said that's something that's going to be my limit. I know, we've gotten really busy, and we're booked a little bit far out. And of course, if I added more surgeries to each day, then I wouldn't be, people wouldn't want to have to wait as long. But I'm not willing to do that. I want to be able to dedicate as much time as I can to the patients that are here, and also, I want to be kind of, energetic and fresh with every surgery. So the limit is 5 surgeries, and that's the way it's going to be. It's not going to be any higher than that. And then, what was the follow-up question?
How do you determine the order of surgeries per day?
Right, the order. So the order, I usually do more what we call surgical cases, the ones that require incisions. I usually do those first. So I have like a mommy makeover, which is typically breast combined with a tummy tuck, or we do what we call the trifecta perfecta, which is the brachioplasty, breast and tummy tuck. If I have one of those cases, that'll typically be the first case of the day, and then the more kind of lipo BBL cases would follow that. But it also has to do with the patients themselves. So if we have someone who is either hypertensive or diabetic, you don't want to keep those patients NPO for a very long time. So those patients then we tend to put towards the beginning of the day as well. And patient preference, we can take that into consideration, but really the other 2 factors will take precedence over that.
So why do you offer body tight as opposed to J plasma?
Yeah, so I think actually we put it up recently on the Pure IG. I don't know if you guys are following that, but there's a few. So the energy that's being used is very similar. It's radio frequency waves that are used in both machines. Okay, and what they do is basically they heat up the tissues from the inside, so they heat up the skin from the inside, and that causes an inflammatory response, which then leads to skin tightening. Okay. The reason I like the body tight over the Renuvium was for a couple of reasons. So one, the body tight has a feedback mechanism which tells you how hot the skin is, and it alerts you if it's getting too hot. Okay, so I really like that safety feedback mechanism that they had with the body tight. And then the second reason is because the body tight was more versatile. So the Renuvium came basically with one kind of handpiece, one size, which you can use for kind of bigger areas such as the abdomen and the arms or the thighs, but it didn't come with like little small hand pieces. The nice thing about the body tight is that it comes in 3 different sizes. The one that's actually called body tight, the one's called face tight, and the one's called AccuTight. So the body tight, yes, you use for the belly, the back, or the arms or thighs, but then the face tight you can use for areas like in the neck and the chin, and then the AccuTight, which is the smallest probe that they have, can be used in like more delicate areas such as the lower eyelids. The AccuTight can also be used and I don't do this here, at least not yet. I haven't gotten the training that's necessary, but it may be something that I plan to do in the future. But you can use Accutite as a form of a non-surgical labiaplasty, which I think is really, really awesome. And that's something that I'm definitely going to be looking at into the future. I'm definitely going to get some training in that, because I think that's one of a service that we don't have here right now at Pure that I would like to provide in the future.
After a BBL, how long do I have to wait to go on vacation?
Well, if you really, really want to enjoy your vacation, I would say at least 6 weeks.
Good answer.
Okay, the reason for that is because before 6 weeks, you can't, submerge the body underwater. You can't do any lifting. You can't do any strenuous activity. So, if your vacation is going to be to kind of, watch TV all day, then you can do it before that. But if you're going to go on a vacation where you really want to enjoy yourself, you want to go out and about, you want to, dance, you want to go to the beach and do all these things, then you want to wait at least 6 weeks.
For one of your patients that you recommended to gain weight for a BBL, do you have any recommendations for foods they should eat?
Yeah. So again, you want to stick to what we call the healthier fats, and so it's similar to the one that you would continue to eat after the BBL. So avocado, salmon, nuts, some milk products as well. And if you're still struggling, gaining weight with all that, then you can take some of the supplements such as Boost, which can help, increase your caloric intake so you can gain some weight as well.
Do all of your patients get drains after a BBL?
For the most part, yes. It's not mandatory, and there are a few patients who don't want it. But I think for the most part I do, it's my preference. I think it really controls a lot of that fluid that comes out the first few days. Maybe the first night, still you have a lot of drainage from the other sites, but after that, most of it just goes down into the drain. The massage therapist can massage everything into the drain as well. And I think it just controls all that drainage without really leaving, open wounds throughout those first few days. So my preference is to leave a drain with all, like with 360 and BBL cases.
If one of your patients wanted to be the first surgery of the day, can they request that?
They can request it, but it doesn't mean we will grant it. Okay, like I said, there may be other things that are really more important, which have to do with the type of case and also the comorbidities of the patient. So, for example, if you're a completely healthy 20-year-old, you can request to be first. But say that if that same day there happens to be a diabetic 40-year-old, well, we're not going to make that diabetic 40-year-old wait. It's because they have to. You don't want to keep them NPO. You don't want to keep them without eating or drinking for too long. So the 40-year-old diabetic would go first, and then perhaps you could go second.
Would you recommend a tummy tuck if I'm not finished having children?
Probably not. I mean, I think if you have like an actual plan to have more children, then it's not worth it. Because you're just going to need another tummy tuck later. Everything that you kind of fix with a tummy tuck will get stretched out again. So I'm talking about not only the skin, but the muscle repair on the inside. So if you have like actual plans to have more kids, it's not worth to do a tummy tuck until you think you're done having kids. Of course, surprises and things can happen to anybody, but if it's still like you're still thinking about it, it's still part of kind of the family discussions, then best to hold off until you're done having kids, and then you can have your tummy tuck after.
Can I get lipo 360 and lipo of my neck, chin at the same time?
Yes. So we can add additional areas to the lipo 360. So the lipo 360 is the entire trunk, okay? And then if you want to add like the arms or chin or thighs, those are all areas that can be added to the lipo 360.
Do all surgeons have the same team that do surgeries with them, and do you?
So, well, my team is always the same team, correct? Yes. So I have two assistants, like I said before. They're always the same assistants, and also my CRNA, my nurse anesthetist, is always the same nurse anesthetist as well. Well, it's the same team. It's her or her husband, but I've been with them for over 2 years, and they're truly, truly excellent. So yes, I always have the same team with me for every single case, and it's kind of funny because if we even have to coordinate our vacations and stuff like that, because if we're not all together, then surgery's not happening.
Do you prescribe anything for anxiety the morning of surgery?
I typically don't prescribe it, but if someone needs it, it's actually okay to take what are called benzodiazepines, so something like Xanax or diazepam is okay to take before surgery. It doesn't interfere with anesthesia, doesn't interfere with recovery. So if you need that, then for either for the flight or for just before surgery, that is okay.
If I just want to get my hip dips filled, can I do that?
You can, yeah, of course. We can tailor. So there's no cookie cutter surgery here. So we tailor each surgery to the patient's needs. So if someone is happy with everything else and they just have a kind of hip dip areas they want to fill out, then of course we can do that. People like different shapes. The upside down heart shape is very, very popular. I think it's also very, very popular with me because I think I can do that very, very nicely. But not everybody wants that. Some people want more of a bubble. Some people want more projection, less projection. So all these things have to be taken into account when we plan the surgery to try to provide the most optimal result for that patient.
So with a BBL surgery, which also includes lipo 360, can you still do lipo on the arms and be within the 4 liters?
Well, be within the 4 liters depends on the patient, right? It depends on their BMI. So if you're on a higher BMI patient, so say 30 and above, typically you have the 4 liters just in the trunk. If you're the lower BMI patient, say 22, sometimes we can do thighs, arms, trunk, chin, we can do everything and not get to the 4 liters. So that really, really depends on how much fat is on your body.
What is best for a person to get first, a BBL or tummy tuck?
So that really depends on the patient, and a lot of it has to do with how much skin laxity they have. So if you're a massive weight loss patient, say you lost 100 pounds, most of those patients have a lot of skin laxity. It's best to do the tummy tuck first. Remove all that excess skin, get things kind of nice and flat, and then go ahead and do the BBL. But if you don't have a lot of skin laxity, then the opposite is true. It's best to maybe do the lipo 360 BBL. See how the skin retracts. Of course, I can't guarantee it. I can't guarantee how well the skin's going to retract, but for many patients, it retracts well enough that they don't even need or want the tummy tuck afterwards, and that's always a possibility. So for those particular patients, it's actually beneficial to do the BBL or lipo 360 first, and then potentially they may not need the tummy tuck afterwards.
Going back to the hip dip question, this question is, can you add hip dips with a mommy makeover? Can you fill the hip dips?
Yeah, usually no. Usually I don't combine fat transfer with a mommy makeover. So mommy makeover is already a fairly large procedure. We're typically doing a breast procedure with a tummy tuck, and so that is a pretty long procedure in and of itself. And then of course we're limited to only 1 liter of fat removal at that time due to the laws here in Florida. So in general, I don't combine a mommy makeover with fat transfer.
Will you combine a BBL with a breast dog?
Nope. Right. So again, in Florida we do a breast dog, then it would be limited to only 1 liter of fat removal, which is for most patients not a significant transfer. So that's why we have to separate it out so that we can then try to increase our limit from the 1 liter to 4 liters for that BBL, try to really get your best results there, and then of course you can come back 3 to 4 months later and we can do the breast dog at that time.
Okay, I know you have to go, but last question. Can you book before losing weight if you don't meet the BMI?
So we've kind of changed the rules about that a little bit because we were getting a few cancellations, people that had done that and then gotten close to the date and they were nowhere near the BMI they had to be. And then that wasn't fair for patients that have kind of been waiting to get on the schedule. So we did change that rule a little bit. So you have to be fairly close to the max BMI before you can actually book a date. So my max BMI, as you all probably know, is 33.5. So you want to be, if you're close to 34, if you're in within 34, 34.2, whatever, but you're like 34 or something, then you're close enough, and then you can go ahead and book that date. But if you're like 36, 37, 38, you got to work on the BMI before we're able to schedule your date.
Okay, one more question.
Sure.
Can I change my surgery at the last minute, like pre-op day?
Sometimes you can. So that's why I like to see all my patients, at least a day before surgery. We have a lot of patients that come from out of town, and so they don't want to be spending a lot of time away from their families and their homes. But we need that time to come up with a plan to make sure that everyone's on board. So I do see all my patients at least a day before surgery, sometimes a couple days before surgery. And if we need to change the plan and we need to go, say, from a BBL to a tummy tuck because the skin is just too loose or something of that nature, then yes, we can certainly do that. What we can't do really though is go from like a very small surgery to then a huge surgery, right? So if we have someone coming in and we're all planning for, say, a 30 to 45 minute breast dog, and then you show up and I want to do a tummy tuck and a brachioplasty as well, then that's not going to work. That's because then just the timing, the way that we organize things, it doesn't allow to go from a 30 to 45 minute surgery to a 3-hour surgery. Okay, but if it's kind of within the same range in terms of timing and everything else, then yes, we can do those changes as needed. Okay. All right. So just before we wrap up, I know I got this question a couple times, so I'm just going to go ahead and give you my answer for that. And that is, people have asked me about dents. Okay, like a true dent, and a lot of people have either cellulite, or they have a dent due to scarring, or they just have a dent just due to their anatomy in their buttock. Okay, so the first thing I want to mention is that not all dents are created equal. Okay, so the dent that's due to cellulite is not the same as the dent that's due to just your anatomy, which is not the same as a dent that's due to scarring from either a prior injury or an injection such as a vaccine. Okay, and what causes the dent? So the ones that are due to cellulite and anatomy are typically due to fibrous bands. Okay, and the ones that are due to a prior injury are typically due to scarring. Okay, and so when we do a BBL, we try to break up the fibrous bands with the use of our cannula. Okay. I heard somewhere that some people said that sometimes the vaser can be used to break up the fibrous bands. That may be a possibility. A vaser uses ultrasonic energy waves. Okay, it's not the same as the ultrasound that I use for imaging. Okay, it's a completely different ultrasound. So I don't have a vaser here. I use a micro-air, which is a power-assisted liposuction. Okay, and that is what sometimes those vibrations with a micro-air can be used to try to break up some of those fibrous bands. Fibrous bands tend to be easier to break up than scar tissue in general. Okay, now having said all that, dents do have a recurrence rate. They do tend to come back. The body has basically has memory. Okay, and they do tend to, sometimes they improve, say, 30%, 50%, but they can come back to a certain degree. Okay, because sometimes it's very, very difficult to break up all those fibrous bands without going overboard. And here, this is the key. This is the key. If you have a buttock and it has a dent due to fibrous bands, okay, you can use your micro-air, you can use your cannula, you can try to break them up as much as you can so that you can try to pop that dent out, and then you can fill the area with fat, okay? But if you do too much, if you go on the other side, okay, you break it up, you completely break off the skin from everything else, okay? What could potentially happen, and it's happened to me once, is that you go from a dent to a bubble, okay? Because you completely destroyed all the bands there that are holding things together. You then you put some fat in, and it kind of filled that space, and it went from a dent to a bubble, okay? And then that tends to look a lot worse than a modified dent. So that's why you don't want to be overly aggressive when you are trying to break up and fill up a dent, okay? Because if you're overly aggressive, yeah, sure, you can go in there with a knife, right? You can go in there with a scalpel blade, make a little incision, and just kind of sweep and completely break it all up. But when you do that, then you're going to overdo it. You're going to create a bubble, and then that's going to be difficult to fix afterwards, okay? And you don't want that. So you if anything, you want to err on the side of fixing it some, but not overdoing it, because once you get to a bubble, that's a much more difficult problem to fix. Okay, so I hope that kind of explains that. And I think this was a very educational talk that we had here today, so we're going to try to go ahead and save these ones for you, and of course they're going to be up here on the Pure IG and on my IG for the next 24 hours or so, and perhaps we're going to try to put this up in the Facebook group as well. Okay, everybody, so I hope you enjoyed it. The questions were awesome. I'm really looking forward to seeing everybody next week in Hump Day with Dr. Alex Earle. Take care. Ciao.